Welcome everyone to the January 2025 CCO Club Q&A webinar. How is Laureen and Alicia tonight?
Doing good.
We are doing good.
Happy
We
to
got
be
the old
here.
gang here again, and Boyd here in Flint, Michigan, along with the CCO team, the head honchos here. And welcome everybody to your CCO Club Q&A webinar. This is all about you, and we have some special topics coming up tonight, and Alicia's going to be doing that, and Laureen's going to be in the chat managing your questions. So I think we got all this covered. You got any other things you want to say, Laureen?
I just want to say Happy New Year. It's January 2025. I think it's going to be a great year for us here at CCO, and we hope it will be for you. We've got a lot of good stuff we're going to share along the way today. So happy to have Boyd back helping us.
And Alicia.
I love seeing where everybody's coming in from. So thank you guys for doing that. And I just saw Sarah Cook. Hello from KC, Missouri. Go Chiefs. Just a hop, skip, and a jump from me. So yeah, that's right. Go Chiefs.
Nice.
We did have a little goof up we should talk about real quick. This is the last Thursday of the month when we do our CCO Club webinar. So if you're not a CCO Club member, I'll put a link in shortly and you can check that out. Everything that Alicia is going to present tonight, the handouts, the recording, will all be in the club. And that's really convenient because if you can't make it live, you can watch the recording and still get the CEU. But we made a mistake and we promoted this as a Find a Code sponsored one and said that the CEU was free. So we went ahead with that. So if you're not a club member, you lucked out tonight, but we would encourage you to be a club member to get those extra CEUs.
Awesome. I shared a little bit of the locations that everybody's coming from tonight. So we've got a lot of views already and a lot of people in here. So thank you for joining us tonight. So Alicia, you ready to go?
I am.
Awesome. So we'll be in the background supporting you whenever you need us.
All right, guys. So again, this is our January 2025, the CCO Club Q&A webinar. The Q&A means you have the ability to ask questions as we go. I know that some of you may be familiar with the CCO Club. If you're in the CCO Club, give us a shout out already. Let us know how much you enjoy it. If you're not, take that opportunity to ask somebody if it's worth your while, because I guarantee you it is. The great topic that we have tonight is a coder's guide to value-based care. Value-based care, we're abbreviating it VBC tonight. That's just the common abbreviation for it. It made a huge shift and impact probably in the last 5 years. It's been around longer than that. However, in the last 5 years, you start seeing it talked about by the clinicians and the providers, the doctors and the nurse practitioners. There's a huge shift to value-based care. Well, what does that mean to us as coders? It's not the same as the traditional how we got paid in the past. There is a new focus, and it's kind of the way medicine was practiced back in the day. You know, you got sick and the doctor came out to see you, or you went and saw the doctor and you paid for the service based on how sick you were, based on how much time and medical decision making that doctor had. So if you had a bad tooth, you might give him a chicken, but if your wife had a baby, he might get a pig out of it, if back in the day. Well, it's of course advanced since then. Let's talk about how we're going to increase your knowledge base. We're going to go over some specifics. We're going to talk about going beyond the basics to understand value-based care, because you can Google value-based care and get an overview. So we're going to break it down and see how that's going to be applicable to you and what knowledge you're going to need to know to be more effective in your role. We're going to review how to achieve accurate coding. Now, we are not going to go in and dig in tonight and look at encounters and charts and stuff. We can save that for another time. In fact, I think it's maybe in March. Heads up, I think we're going to be doing some complex cases then. But it's very important that we figure out how are we going to achieve accurate coding. And value-based care is based on the ICD codes more than the CPT codes. We're going to highlight and capture care complexity. What do we need to do that? And we're going to explore some coding trends out there. I suspect that I may be using some verbiage that you're familiar with some coding trends. Let us know in the chat if that is something that you're familiar with, or if the what I tell you is new to you tonight. We're going to track and close gaps in data. That's really important, and that relationship with the coder and the clinician or the provider has to be good to be able to do that. We're going to talk about setting goals for a multidisciplinary team. Gone are the days when we had a doctor and a nurse in the office, and that was it. Oftentimes, there's multiple roles in one office. You may have one person that wears many hats, but there's multiple people in the office. And now, as practices join each other, we see different health specialties within a physician-based system. Value-based care. There's really been a shift from volume to value. In the past, everything was based on the CPT codes. So if we were doing E&M, the revenue was based on how many E&Ms you could do in a day. How many procedures could you do in a day? How many patients could you run through the door in a day? And that, after years and years of that, frustrated both the providers and I believe the patients, because wait times were long. It was difficult to get into your provider. And then when you did see the provider, you only had these real short windows to be able to tell them your concerns and for them to actually address them. And we didn't have the opportunities like we do now with telehealth originally. So with telehealth, you think, well, we can still do volume because the patient doesn't have to come in and wait in a waiting room. We can meet virtually. That allows you to see more patients, but still it's not beneficial to both the provider or the patient in the long term. I think we figured out statistically. And there was a huge push to go back to value, because value prioritizes the quality of care and the patient outcomes as well as patient satisfaction. Now, as that pendulum started swinging to the value-based, we started hearing about risk adjustment and HCCs and diagnoses, and there was a STAR measures put in there. Some of you guys may be familiar with those. And then with the major payers, we were wanting satisfaction surveys and so on and so forth. It became a even bigger business than what it originally started out to be. And I think, again, that, like I said before, frustrated both the providers and the patients. I found this cute little comic, and the verbiage or the statement was hilarious, and some of you can probably attest to this. It said, I have the results of your blood test. Your health insurance has lowered the acceptable range of values, so you won't need any follow-ups. And that's exactly what has happened. Instead of the provider or the clinician stating, you need to come back in 3 months so that we can test your blood sugar, your A1Cs, or let's check your cholesterol again, or, whatever test they want to do based on a code range, the payers say, we're not going to pay because that patient's range lab value was within our window of standard or protocol, not what the provider saw. And that didn't take into consideration other diagnoses that the patient had. That's how we know an A1C is only some payers will only pay for it to be done twice a year or 3 times a year. Some will pay 4 times a year. And so the provider won't do it. Maybe a patient needs it more often than that. So the control of the patient care has been taken out of the patient and the provider's hands and put in the power of the payer. And that is the opposite of what value-based care is. That lowers the quality of care, it lowers the standard for patient outcomes, and it definitely lowers satisfaction for the patient and the provider. In addition, value-based care, we're going to see key principles that you want to keep in mind. It's consistent measurement framework. That's one of the key things. We want to see statistically if we are measuring let's use that lab value, A1C, for example. If we know statistically that we follow an A1C more than 2 times in a year, then that we see improved outcomes for diabetes because there's better control because we're getting feedback from the lab work. That's a consistent measurement framework. Collaborative healthcare delivery. With value-based care, we're seeing a collaboration not only between providers and specialties, but it's between those working in the office. Patient-centered care model. When we have a patient that is the focus, not on the payer, and it's not just the payer that ends up being the bad guy, if we want to put it in a negative. It's also regulations and some of the protocols have gotten out of hand. So we're focusing on the patient instead of we need to keep this standard or we need to have this many patients come through our doors. Cost-effective treatment strategies as well. Now with that, we're not just looking at what the provider or the clinician is stating. We're taking kind of, as they say, the whole village to develop treatment strategies. So what if that's the key principles, if that's what we want to achieve, then what's the core objectives? And I would urge you to maybe write these down if you're not part of our CCO club, because if you are part of the CCO club, you're going to get access to the side deck. But it would benefit you to talk to yourself, list these out, and how you play a part in these roles. The core objectives: improve patient health. Now, that would be the number one goal, no matter who you asked. It should always be to improve patient health. However, we also want to think about enhancing care quality. It's not quantity, it's quality. And optimize healthcare spending. A lot of resources are devoted to outdated measures, as well as making patients go through protocols to be able to get the care they need. An example of that would be you need an MRI, but the the payer states or the protocol is, well, I'm sorry, but you have to have an X-ray, then you have to have a CT scan before you can have an MRI, or you might even have to have an ultrasound, depending on what the situation is, before you can have the MRI, instead of just going and getting the MRI first. So all of those other steps frustrate the provider, frustrate the patient, and end up costing everybody in the long run more money. Promote meaningful provider collaboration. And it's really important that we understand what our role is. We are a part of the team. I think sometimes coders feel intimidated that they may not be an integral part of the team for improving patient health, when in actuality, we're the ones that capture those statistics. We translate the health status of the patient based on the documentation and what procedures uh, are being done to the patient that improve. So everything that we translate gets put into a database, I guess you could say, and then that is viewed by all the great smart people of the world globally that decide, hey, we don't need to have all of these steps done when a person has possible appendicitis. We now know that we can do, instead of A, B, C, D, we can just go straight to E and get a definitive diagnosis quickly. So that collaboration is really important, and we're a part of that as coders. It all really boils down for us that we capture accurate codes. I say all the time, those of you that have been with us for a long time have heard me say this, and because it really is true. We code for statistical purposes. It happens to be a convenient way to get paid. If we're not coding accurately, if we're dropping the ball and not getting the information translated properly, or educating our providers and clinicians in the documentation that is needed for us to actually translate properly, then we're going to lose those statistics. And in the long run, patient care is going to go down. The health outcomes are not going to be the best. So what do we do to be more accurate at coding? Well, since we know that it plays a significant role in value-based care, we've really got to stay on top of ensuring that the providers are reimbursed fairly, and that the data collected really reflects the true complexity of care provided. With the change in E&M, which I am so thankful when they dumped the old system where we had to click off all of the boxes on the audit report. Did they look at the ears? Did they look down their throat? Did they tap them on the knees? All of that stuff, and went straight to medical decision making and time. Brilliant. And that truly is based on value-based care. How much better could it be than saying how sick the patient is and the time involved with treating the patient is how we're going to do our E&M and reimburse our providers. So to achieve accurate coding and capturing care complexity, we have a few things to focus on. We're going to look at the reimbursement, of course. The payers use codes to determine appropriate reimbursement for services provided. Now, this really truly includes both the CPT and the ICD. When we look at the CPT codes, that is what pays, think of it this way, that's how they get paid monthly. All right, that's like their paycheck. But the diagnosis, that's the big bonus paycheck, especially when you're looking at risk adjustment. So they're getting the income from the payer based on what's done to the patient, and then based on the score of the patient's health maintaining or improving, then a big lump sum of the money comes in a couple times a year. And if we are not capturing the data accurately, that big lump sum based on the complexity of the patient is lacking. Data analysis, again, the codes that we translate off the documentation enable us to analyze the healthcare data. We know that a specific medication works very well when combined to treat hypertension. And that's how we get drugs like lisinopril, which is a hypertensive medication, as well as a medication for water, fluid buildup. We know that that's needed based on the data. And so they created a drug that has both components in one. That's a simple example. It also reveals trends in disease prevalence, treatment effectiveness, and resource utilization. We may forget sometimes what the coding originally started out. It was to track more mortality. How many people were dying globally? And then they were able to narrow it down. Well, if they were dying globally, what are they dying of? Old age? Are they dying of tuberculosis? Are they dying of the bubonic plague? Are they dying of influenza? Again, we're able, what's the mortality birth rate? All of that's done based on the codes that we submit. And that is going to, in turn, show where the need is. If we have an increase in infant mortality rates, then that's the focus, right? So those statistics can be really, really fascinating. Quality measurements. The codes help track the measures to measure quality metrics, ensuring providers meet the value-based care standards. So again, based on the key principles and the objectives, we have a set of standards for value-based care. Therefore, to ensure that we're meeting those standards, we're using the codes to do that. Now, in retrospect, when you think about that, how important is it for you to not use an unspecified, CHF code versus one that states that the patient has systolic or diastolic or combined or acute? It's really important to know those statistics. There's certain medications that work better for systolic versus diastolic, and the progression of the disease process. Diastolic is usually where it starts, ends up systolic before it becomes end-stage heart failure. And we know that based on the statistics. If we drop the ball, we're not going to be able to have accurate quality measures. Then we have implementation. What are we going to do about it? To ensure that accurate value-based care is implemented, we have a few essential practices. The very first one, which really is, this is probably redundant for me to tell you, we all know this. We have to have a thorough understanding of the guidelines. The guidelines were created to allow us to translate properly. And one of the most basic guidelines for any of you that are new to coding or are interested in thinking of this as a career, one of the first guidelines that you learn is a default, and it has to do with diabetes. And we, as educators in coding, tend to joke about, if you want to teach anything in coding, you can usually use diabetes as an example because it affects so many different parts of the body systems and the guidelines. If the provider doesn't state in the documentation whether the patient is a type 1 or a type 2 diabetic, we default to type 2. That's a guideline. And you think, well, why do they do that? Well, the disease process has told us that 98% of all diabetics are type 2. So it's not even a 50-50 guess. Chances are you're going to default to the right one because of those statistics. It doesn't state that in the guidelines. The guideline tells you if there's no documentation, you default to this. Another simple guideline that's similar to that would be the fact that if we have to determine dominant and non-dominant sides for usage, say, in a stroke victim, if they don't tell us, we default to right because most people are right-handed. So again, some of the guidelines are incredibly practical, and then others are on a higher level intense based on a more in-depth understanding of a disease process or a policy or a procedure. But we have to stay on top of that every single year. If we don't stay on top of it, then the statistics can be skewed, and then value-based care is not going to be able to be implemented at the highest capacity. We don't want to have errors. And not only do they infect reimbursement, and that's what most people talk about, but it really is a part of quality reporting. In doing this, we need to conduct comprehensive reviews of medical documentation. If you've been working as a coder for any amount of time, you realize how important documentation is. Now, as clinicians and providers go to school, this is something that they're educated on from the beginning. Day one, they're telling them, documentation, if it's not written, it's not done. They're told this. And then they're taught protocols and procedures and how to document different disease processes, as well as procedures that are done, standards of how they have to document a procedure or a surgery, so on and so forth. And that's kind of stuck and run, done in their head. However, we have to translate, and they don't know the translation is a different language than what they speak often. It would be wonderful if it was based, the translation was based. Let me back up. If the definitions of the codes were based on the way providers talk or document, but it's not. Unfortunately, it's gotten better through the years as code sets have changed and improved. So it's our job, twofold: one, to capture the documentation accurately, but also to inform and educate the providers and the clinicians on specifics that need to be documented so that we can capture the codes at the highest specificity. And you're not going to be able to do that if you don't have a good working relationship between providers, clinicians, and coders. Documentation is truly the key for getting things done, and it involves reviewing physician notes. You've got to look at lab results and health information that's captured over all relevant diagnoses and procedure to be able to take care of the patient as a whole. In doing this, the best thing you can do is have audits. Most people, when they start in the industry that we're in, audits is a scary word. And in fact, providers don't like to hear that word either. It usually means that you've done something wrong. But I would urge you and encourage you to think of it in a different way. Being audited is an educational tool. When you routinely have audits, it's going to identify coding errors. And if you make a mistake and are informed about that mistake and given the rationale, you don't make that mistake again because you're educated. You're now wiser on that scenario. if you don't allow for corrective actions to be taken before claims are submitted, then they get bounced around in this behemoth of waves that sometimes they just ultimately drop because nobody tends to communicate, or it takes so long to communicate between all the different players. Audits can highlight patterns. They can show recurring issues in documentation, and you should relish being audited. You should internally audit your Office of Coders. You should have a hierarchy where you're being audited amongst yourselves, and then you have more experienced or oversight auditors coming in and auditing. And then you should have outsourced or external auditors coming in, because even if you think that you're really good and you understand the process, they change things all the time, or we learn something new about a disease process or a procedure that would in fact change the way we would translate. So again, I encourage you to relish being audited, learn how to audit each other. It's just like you were in school, and it's not you could say it's taking a test, it's taking a spelling test, but guess what? You not only do you get the memorization of the word, but it makes you more articulate, right? So it's a very positive thing. Never look at it as a negative. We also need to be on board to provide ongoing training to the coding staff. And I would say not just the coders, but the clinicians, the providers, everybody needs to be uh, allowed training, ongoing training, because again, you have to have that communication. If you start telling a provider that they're not getting paid because for a procedure or something that they had routinely or historically been paid on, they're going to be frustrated and confused. If you tell them that they can't use that code anymore, we need to educate them on what the change was. And the same way, we need to be training our coders and letting them go to things like this, webinars, and networking to increase their knowledge base. Stuff changes so quickly in our world. Now, the other takeaway is the best practice for audits should be multi-level, like I said, internal, external audits with a minimum goal of 95% accuracy rate. And if you work in risk adjustment, it actually is higher. It's usually 98 or 99% accuracy rate because there's so much revenue involved. Coding trends to track. Risk adjustment, HCC, hierarchical condition category coding. This is crucial for risk adjustment in value-based coding programs. Again, it's all about the diagnosis code and how well the patient's doing, quality over quantity. Chronic illness and disability payment systems, which is CDPS, understanding the system is vital for accurate coding in value-based care, as well as the RAF scoring, risk adjustment factor. Now, this helps to determine the complexity of the patient care. And these RAF scores are captured every year. They start on January 1st again. So if you have captured that your provider is treating a complex patient, guess what? January 1st, that patient is a healthy patient again. They have to start over and recapture all of those chronic and complex diagnoses every single year per Medicare. And that is problematic usually, uh, uh, especially when patients don't come in and see their doctors as often as they should. So closing the gap, that's actually the goal. And this is what you should go back to your office saying, let's do an audit, determine where these gaps are and what we need to do to close the gap so that we have better communication between the provider and the coder, as well as getting any benchmarks or trends that we're seeing bounce back from payers, and close the gaps in RAF scores, so we're capturing the complexity of the patient. The ways to do that is to ensure comprehensive documentation of patient conditions. This is, again, not just something that the provider needs to deal with. This is the coder telling the provider the changes in the code set and the verbiage that's needed for accurate coding. Collaborating with the clinicians to capture all relevant health information. We have providers that are seeing very complex patients, but the reason the patient came in that particular day may not be complex, but yet it's a very complex patient. And so even though they're thinking about all the complexity, they don't get that down on paper every visit, even though, again, they're thinking it's part of their medical decision making. You can't just give a diabetic or a COPD or any medication for a cold. You have to think that through. And they just do it routinely, so they don't realize the complexity that's involved. And we need to educate them in getting that documented. Also, utilizing coding software and technology to streamline the coding process to reduce errors. Some of it is manual errors with data entry. Some of it is the software platform hasn't been updated or isn't capturing complexity in the same way. I see this a lot with problem lists where somebody has gone in and changed the diagnosis description, and when the doctor looks at the list for the code, they pick the same one every time based on what's in the description or the title, and that's really not what it is at all. And it's not their fault because they don't know how to translate the code. They don't know what the code is. They're going by the title, and somebody went in and changed it. That happens a lot. Working in a multidisciplinary team. I would say that you're probably doing this already. You may not realize it, but in value-based care, medical coders are integral parts of a multidisciplinary team. And to be effective, you have to have a good working relationship within the team, with the ultimate goal always being the benefit of the patient themselves. So to work effectively, you need to be able to collaborate. If you have a problem with collaboration or people or personalities, because I can tell you historically, providers tend to be type A personalities and aren't always the easiest to communicate with. And so, it might behoove you to educate yourself a little bit on dealing with different personality types. It might be as simple as that. So when you collaborate with the clinicians and the administrators to develop effective care pathways, things are going to get done. That's a good statement. I'm finding that to be true with our providers. Be true with our providers and hyperlipidemia. I'm finding that to be true. Oh, with our providers and hyperlipidemia. I got it. Sorry about that. Yes, absolutely. Now, I can tell you that because we have several codes for hyperlipidemia, it it is when you've got pure hypercholesterolemia, mixed hyperlipidemia, and all the different ones, that almost is a battle that's not worth fighting. There's bigger battles to fight, but that's a perfect example. We want to get to the highest specificity. Uh, Moving on to participate in the regular team meetings to discuss patient cases and coding challenges. One of the things that I tell people when we go in and talk to them at consulting work and stuff is that if you have a provider and a coder walking towards each other down a hall in the office and they turn in different directions when they see each other, you're not going to get effective patient outcomes because of that. You have to be able to participate in a team, and meetings is the way you do that. Uh, you've uh, you may not feel like you play a major role in that when everybody's talking about spreadsheets and money and the different um, high level intricacies of a uh, facility or a multi practice um, office, but you really are. You are an intricate role because nothing gets translated properly if you're not on the team. Contribute to the development of coding standards and protocols within your organization. So there's a lot of tools to assist you. One of them is to come out to the CCO club. We have questions come in all the time where we have people in an office that disagree on a certain way to code something or a protocol they're trying to put in place. And it benefits you to kind of get a third party um, answer. Let us do a little bit of research, because you can't just say this is the way we're going to do it. You need to know why, or you need to be able to show a reason, and we can help you find those answers or get you in contact with the people that can, because of the peer groups that we have. Engage in continuous learning to stay updated and evolve the evolving coding guidelines and industry updates. Just working in telehealth alone, look at all the changes that have happened in the last few years, that it just seems like I think it was last year, every day you woke up, you looked at the computer, and there was another rule or change in telehealth. So you can't do it alone. You have to be part of a coding community to stay on top of it, have peers and network to make sure you have the latest information at your disposal. What's the future of value-based care? The prediction is that 2025, as we approach, we're here now, that it continues to reshape the healthcare landscape with significant growth expected. So the global value-based care market is projected to reach 3.77 million or trillion by 2029. $3.77 trillion. That's crazy. That's a lot of money. Emphasizing the importance of staying informed about emerging trends and regulatory changes. Again, that's what we do. To succeed, what you're going to need to do is stay on top of the changes, and healthcare providers are going to need to adapt to do new payment models and risk sharing arrangements. That means we have to be aware of what's out there, what works and doesn't work, because they're going to ask for our input. Leveraging AI and predictive and analytics for personalized patient care. Don't fear AI. It's not going to take your job. It's just going to make you more effective at your job. Focus on addressing social determinations of health. I can tell you there is a huge push this year to capture these SDOHs. That's the talk right now. So if you're not well versed in social determinations of health, or your clinic or office is not actively capturing these, that should be one of your main focuses this year. Prepare for expanded behavioral health integration. That has been a boom for some time, and it continues to grow. And there's always a need for people to make sure that they can work in behavioral health, coding, as well as staff in the office. Staying ahead of these trends is going to be crucial. It's going to allow you to optimize patient outcomes. That's what it's all about at the end of the day. We're going to ensure regulatory compliance. That's extremely important. We're going to also maintain financial stability. We want our providers to succeed. We want our patients to get healthy. We want our providers to succeed in the business side of medicine, and therefore we have stability in our jobs. Regular audits and gap analysis are going to be essential tools. If you're not doing that now, you need to be proactive and be a part of having that in your office, because you can't identify the areas for improvement and close these performance gaps without that being in place. But don't worry, if this has been overwhelming, we're here to help you. You can come to CCO. We have some amazing resources. We have a lot of really intelligent and top-notch peers that are used to doing training and audit services, and they can navigate the world of value-based care, and they can help you close those gaps in a practice. So if you are seeing an issue that this needs to be addressed in your office, whether you're a provider, a clinician, or a coder, check out cco.us and ask for the resources. Now, by partnering with experts, that's really what's going to ensure that your organization is going to be able to move forward and be in a good position to thrive for 2025 and beyond. And that is an overview of value-based care. If you have more questions, I want you to know you can come to us, the CCO Club. We talk all the time in there. A great place to have your questions answered. Laureen, did you want to talk about the CCO Club a little bit more?
I've been talking about it a lot in the chat, but I just wanted to say that you can join anytime. Someone just asked if you have to wait till January. No, you can join anytime. It's $24.95 a month right now at the time of this presentation, and we do have an annual plan that's a little cheaper. But really, if you go to the website and read about the club, we've got a nice page that outlines all the benefits. What you get is all the recordings of the webinars that we do. Yes, you can get a lot of them on YouTube or different places, but we kind of package it up nice. It comes with a transcript. You get the slides. You get an area to ask follow-up questions on that content. You can always go back and, revisit it. And in our area, our platform, you can put in a keyword and you can find, oh, I'll watch that and I'll get a, CEU. So that works out really good. Plus, if you've ever taken a course or a blitz with us, by being a club member, you get access to that course indefinitely. So people like that. So as we update courses, they want to go back and refresh themselves on something. They have all that content at their fingertips, all within the same platform. I'm sure there's many other things, but just go to the page and you'll see about it.
I have a question for Alicia. Alicia, you talked about the future of VBC. What are 3 things that you would recommend to people taking advantage of this 3.77 trillion market by 2029?
It really is a matter of revenue, more so than it was in the past. So the 3 takeaways I would say is that you're going to have to do an initial audit of where you stand to see where the gaps are. And then you're going to have to set in place policies to close that gap, create educational scenarios or trends within. Maybe that may be bringing somebody in to educate the providers. It could be bringing someone in to educate the coders, or both. And then continue to do those audits routinely and close those gaps that you see. There is several models that are out there that you can use, or starting points. There's so much diversity in what you can capture, but to do an initial audit to see where are the gaps, where are we falling, who's slipping through the cracks, do that first, and then do a narrow focus and see what steps you can do to improve. So those would be the 3 things.
Thank you.
Did you want to talk about our QPIN course, Laureen?
Well, I'll kick it off, but this is Alicia's baby. She did this all on her own, created the whole course, worked with Sylvia on our team and pulled this all together. But we're very proud of her. But I'll let her tell you all about it because it's her little passion project.
It really stemmed for providers asking for education with a new code, and particular practice came to us and said, "Can you educate and give us more information about the G0023, the Principal Illness Navigation Services that we'll be able to offer because of this new code?" And sure, we can do that. That's what we do. However, the more I talked to them, I realized they weren't set up to use this code properly. It wasn't what they thought it was. And with that, we counseled and determined that they needed the people who were going to implement the use of this code to be educated. This was originally, patient illness navigation originally was based in cancer and oncology. And then it was opened up to all chronic conditions, not just chronic conditions, but severe illnesses and stuff that would, I mentioned it before, people slipping through cracks and not getting the services that they needed. And so we created a course so that the people that they had that wanted to be patient illness navigators would be trained in the process. And then with that training, they could, with confidence, offer the service, and the patient outcomes were fantastic. It's not a very difficult course to get through. We did design it for people who do work in the medical field. Ideally, if you have a CNA or an MA, or LPNs, RNs, any clinicians like that, but they are fabulous to take care of patient illness navigating needs. That also closes the gap. I think of it as a liaison between the provider and the patient, making sure there's good communication and all the resources that the patient is entitled to, they actually get. It is, again, a fast course. We called it qualified principal illness navigation, or was I'm a little hazy on what the actual acronym ended up being for. QPIN, qualified principal illness navigator. That's what it is. Stumbling on that. So if you want to know more about that and how you can offer this service in your office, let us know. cco.us/QPIN-course. It's an exciting course. We have some other news.
This is the best slide. I mean, as far as promo slides go. So we have our internship program open again. We have spent a lot of time on a new platform. Actually, it's been so busy, I had to go up to the next tier of all the data that's been hit on it. So if you need to get some intern time in, come check us out. We've got lots of really cool projects that people are working on. A lot are working on ICD-11 stuff. Mm-hmm. So you learn as an intern. You're not doing like making copies in the back room kind of thing. You are touching coding, you're researching stuff, and you're collaborating with the CCO team. So I'll put a link in a minute to be able to fill out an application for that. The monthly webinars are back, and Alicia's going to be taking the lead in that. I'm going to be her little Vanna White, and hopefully Boyd will be able to join us for a lot of them. That's the last Thursday of every month at this time, 8 p.m. Eastern. And the next topic for February is going to be AI and medical coding, advancing patient outcomes. So that will be an interesting one. And then our announcement is Find a Code loved the sponsorship that they did at the end of last year for the CPT and ICD updates. So they asked us, can we do more of that? So we came up with doing an ICD-11 series, and that's going to start February 13th. Oh, did my slide update? Can you refresh your slide, Alicia? Because I had updated it.
Let me
I don't know if you hit F5 or... There you go.
Let's see.
Just the top
right.
one.
I'll just slide through.
That's okay. Quick. So the first one with Find a Code sponsorship is going to be February 13th. That is going to be done like how we did this one tonight, where you can get the free CEU. We put it in the StreamYard at the end. That's only for live attendees. And then the recording and the CEUs for club members will be available in the club as normal. So that's going to bring our club CEU count more up to like 24. We advertise 13 on the site. So that is going to bring a lot more value to the club members. Plus the public can still benefit from the Find a Code sponsorship, but you have to attend live, not the recorded version. So thank you to Find a Code. We're really enjoying working with them.
And the first topic, the very first presentation, post coordination in ICD-11 using STEM codes and extension codes. That's really the basics. It's the structure of ICD-11 that we'll be talking about and how important that is. So I know if some of you guys have been looking into ICD-11, it may be intimidating, but I think this new series will unpack it for you. And then you'll be the leaders in your office or your entity wherever you work.
Yes.
By being proactive.
It's very different.
And it's fun.
Yeah.
And again, thank you to Find a Code for sponsoring that. You guys know that we really like Find a Code because it's education-based encoder, better than all the others, I think, in our opinion.
Alicia, if I can just stay on this slide, in the chat, this happens every time. You have to be a member of our free forum. That was in the registration link when you registered. And you have to log into that free forum and then click the link that I put in StreamYard, and you'll see the quiz. It's one question. And you put the password in and you get your CEU. That's how we do it. We don't need to see your AAPC numbers in the chat. You know, we don't. The proof that you attended is that you logged into StreamYard and you were here the whole time. You know, so we have had some people come and say, well, I was on, but we had proof that they're only on the last 5 minutes. So to get that CEU, you have to attend live for a majority of the time. So that's how it works. So you click on the link and you have to be logged in, answer the one CEU quiz question, and then put the password in. Okay. I give you the password in the StreamYard because we don't want to put it out on YouTube and LinkedIn and all that, because then, we lose control of it. We don't have any proof that you actually attended, and people can see the YouTube recordings, a year later. So that's how we're doing it. If you have any trouble, you can reach out to the help desk. But if you're going to be joining us regularly, learn that routine and you'll be good. Once you join that free public forum, it'll be very smooth going forward.
Nice.
That was it.
Exciting. Now, if there's a particular subject that you want more information on, we are very receptive to that. Go to cco.us/topic-request and let us know what your needs are and how you want to increase your knowledge base, and we will be there to support you.
Yep. And I'm going to put the link in right now for the intern application. If you know anybody, send them our way. I think our interns are really enjoying it, and it's very smooth for them to put in their hours. And when they meet that requirement for those that are AAPC certified and they have the apprentice on there, then we write a letter once they achieve a certain amount of hours, and that helps them to remove their A. So come work your A off with CCO.
That's right. And really have some unique opportunities to do something that you probably won't get to do at other places.
Someone's asking, where is the forum? The forum is the link that I gave. It's here, I'll do it one more time.
Show it again, yeah.
Rashad Khan is right. Value-based care is growing by leaps and bounds. It truly is. It isn't the wave of the future anymore. It's here, and it's so it's important that you understand it. You may even be asked about it in an interview. Do you know, are you familiar with value-based care? I was one time, and now you can say you are, that you've had webinars in it.
Yeah. If you're getting an error, this happens sometimes because there's so many people hitting the server at once. Just be patient, try it again. It normally resolves itself within a short amount of time. But we promise you, if you attended, you're on StreamYard and you've tried everything and you reach out to the help desk, we'll make sure you get your CEU. But yes, it was really, really well done, Alicia. And, if you guys have any general questions you want us to answer, the webinar is officially over, but Alicia and I love kibitzing and helping you guys out with career advice, exam advice. We've been at this for many years.
Yes, the webinar is officially over, so I can tell you that I am in my office, but I've noticed over my head that you keep seeing something hung up. Those are 2 antique wedding gowns.
Oh, wow.
One is almost 100 years old, but I forgot. But for some reason, they keep popping. I thought, oh, no, they're going to think my laundry's hanging up. And they're like, no, those are antique wedding gowns I have hung up in my office.
That's
Sorry about
cool.
that.
We'll have to have a separate
It's caught
webinar.
my eye a couple times. I thought, oh, dear.
Yeah.
We may use that as a question someday to see if you were attending or CCO trivia, right? What does Alicia have hanging in her office?
That's 100 years old.
Antique wedding gowns.
Yeah, so lots of exciting things going on, guys. Thanks so much for being here with us. And again, if you're having any trouble, reach out to the help desk. Sylvia is wonderful, but give her some time. She always gets slammed post webinar day. I'll put the post in one more time.
Yeah, we have the easy job, don't we?
But I suggest wait until tomorrow morning. If you're having trouble tonight, try it one more time tomorrow morning. And if it's still not working, then reach out to the help desk and Sylvia will help you.
Good luck, Elizabeth, on retaking the CPB. Good job.
Yeah.
Stay in there.
Very good.
Okay. I'm going to end it for us. Yeah.
Thanks, everyone.
So thank you for being with us, everybody.
See you soon.
Take care. Have an awesome day and night and wherever you are.
Yeah.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.